Today we're going to talk about an issue that not only us and our patients are struggling with, but the whole world is struggling with, and that is the um, um, proliferation of human body weight. Our patients are a little bit different, but if you look at what's happening in the US, this is Laura. Can you see my?
Yes.
Okay, so this is 1970s. Green is like below 20% obesity rate, and this is 2022, and the obesity rate in some states are above 50%, and um, and this is the general population. So it is not a uniquely American disease. The whole world is getting, seeing increased obesity rates, but nowhere else in the world sees this rate of increase like the United States does. And which finally ended up obesity defined as a disease by the American Medical Association for reasons I'm going to talk in a moment. And how does it affect our patients? This is rather early data from now almost 20 years ago, but this was the normal non-SMI New Haven population, metro population. It may include some SMI too, of course, but which is like, the obesity rates were about 25%. And this is our patients with schizophrenia. Obesity rates were over 50%, and which reflected in the diabetes rates, which is a direct result of obesity for some people, unless it is juvenile diabetes that starts when people were born or children. Diabetes type 2 is a direct result of increased adiposity, more fat than a person needs. And at that time, we didn't have as many patients in the early psychosis clinic. This is for the first 62 patients. You can see that, and this is a younger population, of course. So you can see that obesity rates were much, much lower in the early psychosis population, the first 2 years of illness. But then we showed that, that people quickly gain weight. I don't have that slide here, I apologize. And the cardiac risk almost doubles, and this is an amazing finding for people who are in 20s. The cardiac risk doubles over a period of 10 year, 20 year. So following starting treatment for psychosis. Is it a schizophrenia or psychosis phenomena? It looks like it's not, because we have data from 1940s, and people were about the same as the general population. The line you see there is the general population, and the dots are the patients. And 8 years after admission, the same group of people, minus the losses, as you can clearly see, there is no weight gain for the same population. This is before we started to treat people with antipsychotics. Now, times have changed since then. If you remember, this is 1940s. I show you the data from 1970s, where the obesity rates were around 10-15% nationwide, and it's about 45-50% now nationwide. So you can imagine that line for the normals went up, but regardless, you could not separate patients from the general population, but now we do, as in the previous slide. So there are specific things about schizophrenia which may cause weight gain. The main thing is, of course, what we call a downward social drift, poverty, which limits the food choices, healthier food choices. The schizophrenia comes with a specific set of symptoms, which we call negative symptoms, which may or may not decrease volitional movement. And of course, eating is one of the few hedonic activities, the pleasurable activities that are left to many patients who are isolating themselves quite a bit. So, but it doesn't appear that these are the main culprits, as you can see in the early data. The direct results of increased weight, increased rates of obesity in schizophrenia is directly reflected in death rates. So the potential years lost per patient is about on average 28.5 years, which means people would have lived 20 plus more years if they didn't have certain illnesses. And although schizophrenia is a disease where suicide rates are higher than general population, most of the deaths were because of cardiovascular disease, which is a direct result of obesity and smoking, which is pretty prevalent. That's the other big killer for patients with schizophrenia, although we are seeing some positive changes in the younger population. And that is reflected right there in the COPD, the second column. And the direct results of diabetes, cancers are a little bit more increased than the general population. And at the end, you see the suicide, which is what we pay so much attention to, which is only a smaller portion of early deaths in schizophrenia. So obesity is something that we need to pay attention to in care of psychosis. We looked at it because we were trying to prevent people having cardiovascular disease once we figured out that that's the big killer for patients in our clinic. And we saw that our patients have even higher cardiovascular risk than their obese counterparts in the general population who do not have serious mental illness. So it's the race about cardiovascular risk doubles for obese people who don't have SMI, and it almost triples or 2.5 times for obese people with schizophrenia. This is data from the chronic patients. We also replicated these findings in the first episode patients that which really surprised us because we didn't expect 20-year-olds have increased cardiac risk. It should be like 0, regardless of if you are obese or smoking. There are other medical complications of obesity. A bunch of cancers are connected with obesity. Alzheimer's is like early dementias. Some dementias are connected. Fatty liver disease, gallbladder disease, obviously osteoarthritis because the joints are not, ready to carry the additional weight patients sometimes have, and there is we've seen a couple of we do see these every day in our clinic. But the biggest thing is, of course, the cardiovascular disease, heart and the strokes. And so since we had not much obesity in different than general population before antipsychotics, and we have it after the antipsychotics, especially after the advent of second generation antipsychotics, which was in the early parts of my career, and we did see people actually gaining incredible amounts of weight. Although these medications saved lives and they were much more tolerable than the earlier medications, they seem to cause much more weight gain. this is like, the general um, um, medications that we use. Some of them are not available now. This is an older slide. But, most antipsychotics that we use today reports over 7%, which is the cutoff, weight gain compared to, not using them, compared to placebo. There is one new medication which is not listed here. There are a couple of new medications which are not listed here, but there's one new medication which is not listed here, which appears to be weight neutral. It's not a dopaminergic agent, which is just approved. I don't have any experience with that medication, so I'm not even going to talk about it because, its antipsychotic effects are in real life we are waiting to see it first. Is it possible to take an antipsychotic and not gain weight? These are medication-naive patients who never use the medication, all first episode patients. And it seems that every antipsychotic does cause weight gain in the first 6 months and then the first 1 year. The worst offenders are olanzapine and clozapine, but it does appear that even the medications we generally think would not cause weight gain do cause weight gain when you give it to people who are just starting the medication without any prior exposure to the medication. And this is very similar study, and they replicated what we found in our study. And this is from patients who do not have psychosis. Antipsychotic, although we call these medications antipsychotics, they are used for a variety of other indications in general medicine. Some FDA approved, some are not. You may be, of course, mainly familiar with bipolar disease, which new generation antipsychotics are sometimes used as mood stabilizers. And as you can clearly see, regardless of your diagnosis. So this brought us to the thinking that this is not a schizophrenia problem, this is an antipsychotic problem, but our patients are the ones who can't do without the antipsychotics, so we have to address the obesity problem. Continuing with the same domain, this is the chronic patients, and every medication does cause some amount of weight gain. However, the trick in this slide is that if you look at the left side on your screen, the overall change in symptoms other than clozapine, and a little bit of amisulpride, which is not available in our country at this time. A version is being developed. Is not much different than each other, which gives you the idea of what, when you're choosing an antipsychotic, the idea of maybe, just maybe, you try the antipsychotic that doesn't cause as much weight gain as the others, because there seems to be a difference in every medication's weight gain propensities. Is it the diet? I'm like, I looked at a lot of things about, like, maybe it's not the antipsychotics. This is my main way of dealing with psychosis. You can't even start the other modalities of treatment we employ, both at the STEP program, at the chronic psychosis program, before we can control the psychosis. And the diet appears to be about the same as the general population. This is the New Haven general population. With similar socioeconomic, we matched socioeconomic level of population control and the schizophrenia sample. So the diet distribution seems to be the same, but the calories are about 500 calories extra. Now, 500 calories extra every day If you look at the standard deviation, maybe a little bit more than 500, maybe the median would come down to 800 calories. That's like um, one non-diet soda, one bag of chips, and one Mars bar would get you there. So that's the only difference. Very simple things are, if taken daily, causes incredible amounts of weight gain over the years. Uh, Now, possible mechanisms, this is more technical. I dealt with this to figure out if we can find a way. And it may be directly related to either the main mechanism of action of antipsychotics or, some other brain actions that come in the package, because there's rarely a very pure medication that affects just one thing. But the reason we study these things is essentially, can we develop better medications or treatments? And lo and behold, the very new medication that we were talking about, it does not have any D2 blockade and does not have any antihistaminic activity. So, and does not have any serotonin 2C receptor activity. So we're thinking that it actually may be really weight neutral. Now, there had been other medications before that are marketed as weight neutral, but when we looked at the data carefully, they still caused quite a bit of weight gain for a smaller group of people. And what to do? Of course, if you can get away with not using an antipsychotic, don't. But for this particular population, we don't have that ability. That's a message I usually tell to give to physicians who use these things for sleep or anxiety. In schizophrenia, we don't have any other options. In psychosis, in general, we don't have any other options. So when we were developing our medication strategies in the STEP program, which is pretty much like what our colleagues did in Europe, we always start with low doses. We always start with medications that we think will cause lower weight gain. It's not for the immediate solve an immediate problem, but it's to solve a problem that will come 20 years later. And excessive weight gain is a perfectly good reason to switch. And young patients in the STEP program often tell us, "Oh, I gained so much weight on this medication, change it." And which is, of course, what they're thinking is for aesthetic reasons, and which does have an impact on social quality of life. But from a physician's perspective, preventing a disease is so much easier than treating a disease, and this is a disease that actually kills people. Does switching medication work from a higher weight gain agent to lower weight gain? Yes, it does, if the medication works the same way. And this is another study. There are oodles of these studies. I'm not going to talk about them one by one, but I'm talking about the very large studies that were done when people switched from higher weight gain to lower weight gain agents. A similar study, and let's keep on going on. So, other than the switch, another thing, of course, to deal with it is that sometimes when the symptoms are not manageable or not to increase some other side effects, physicians use multiple medications. This usually happens during periods of transition from acute relapse to, and when you clear that polypharmacy, go to a single agent, you may often can affect and decrease the weight gain. Now I'm going to talk a little bit about, the treatments that we talk about, how we can deal with it with medications or, forms of therapy. But I always talk about this study. This is this was a huge study, about 5,000 people around the country who were obese, who were at risk of diabetes, but not diabetic yet. They had to stop this study midway because not doing anything, giving people placebo, would cause 40% of the people develop diabetes. And um, um, the people who were put on metformin, which is a diabetes agent, were converting less, and people who were put into extensive lifestyle programs, which includes, dietary control, changing lifestyle habits, and exercise, were actually converting least. The combination of metformin and lifestyle, actually, it's not shown here, was best. So maybe pre-treating diabetes, which is interesting because metformin is an agent that we do use for weight gain control in schizophrenia as well. And in diabetes prevention program, people on average lost about 6 pounds per person when they were put on metformin. And we found that this is a very stable effect in patients with schizophrenia too. 6 pounds may not be too much, but it may be preventing further weight gain. Some people respond quite a bit, but at the very least, this is a medication very well tolerated. At the very least, we add this to prevent future development of diabetes because we have confidence in the data in the general population that if you're pre-diabetic, if you're obese and prone to get diabetes, if we start you treating with this medication, which doesn't have many side effects, you're less likely to convert to full diabetes, which comes with all kinds of complications and early mortality, as I showed in the beginning. And there are recently approved obesity drugs, and this one is called Contrave, trade name. It's a combination of two old drugs, an opioid antagonist and an antidepressant. And it does work in some non-SMI patients. Our experiences with this medication is not very good in schizophrenia. This is my personal experience. There are not that many studies out there which studied this medication, which is a little bit problematic because the antidepressant that is used sometimes may trigger manic episodes in schizoaffective patients, and very, very rarely, super rarely, may cause the exacerbation of psychosis in schizophrenia patients. And since I specialize in very difficult to treat cases, I usually try to stay away from anything that might increase psychosis, at least the ones that are given by me. It's very difficult to ones that the pharmaceuticals that patients provide themselves from the street for recreational reasons. But we did study one of those things, the naltrexone, because we did have a large hypothesis that we thought that people are not, people's pleasure pathways are a little bit blocked in schizophrenia, and perhaps if we block them further, we can prevent. I mean, it works like this: you block a receptor, the brain generates either makes the other receptors more sensitive or generates new receptors. So we thought that by blocking this, we're going to increase the hedonic pleasure and decrease the negative symptoms and decrease appetite. It worked for a group of people who did not have diabetes in a small study. So we went and did a huge study with 150 people for a full year. We gave them naltrexone on 2 different doses or placebo. And we spent 8 years on that study. Sadly, naltrexone did nothing to prevent further weight gain or cause any weight loss. So that was a negative study. There's another recently approved obesity drug, which is called phentermine plus topiramate. It's called, I can't really say this name, Kisimia. It's a controlled substance. Phentermine is something like an amphetamine, and like very close cousin of Adderall. Or another close cousin is Sudafed, which you can buy, behind the pharmacy counter. Um, Sometimes causes psychosis. Another medication that we use very, very carefully. And topiramate is an anti-epileptic. Topiramate itself causes quite a bit of weight loss, but the reason we can't use that very frequently in schizophrenia is it comes with some cognitive loss, some memory, attention, um, to the point that some of our patients called it stupamax, very creatively, from the brand name Topamax. But this is a medication we sometimes use. We try not to use the combination, but this is a very effective medication in general population. But I'm going to show you our experience with topiramate. This is like a 2 year. This is my own patients, and you can clearly see that everybody lost weight and everybody lost quite a bit of weight on this medication. What happened is at the end of the 2 year, other side effects of topiramate hit us. One patient had gallbladder disease. It may be a result of topiramate. It may be the result of weight loss because sudden large weight loss may cause gallbladder disease. And another person had kidney stones, which is a very typical side effect of topiramate. I still think it's worthwhile to explore this medication. But you have to watch for all those side effects. This is another study that's done in Korea. Same effect. Topiramate seemed to be very effective in letting people lose weight. And another study, this time from China, which compared topiramate and metformin, and topiramate seems to be a better medication for weight loss. Of course, topiramate has no effects in preventing diabetes, but there is no reason why these two cannot be used. Metformin is much better tolerated. It may not be that relevant for, I'm going to pass this. This is a supplement. I usually put this in for people who tell me you always study stuff done by, produced by drug companies. Actually, we studied a lot of supplements, which you can't find in the literature papers because they were all negative studies, and it's extremely difficult to publish a negative study. But, whatever supplement touted for good in schizophrenia or good for weight loss in the interwebs, Dr. Tek studied it. Trust me, I did studies with that, and very few things block weight gain. This one did though. This is an antioxidant. We like antioxidants in schizophrenia that because there are some hints that there is oxidative stress going on in schizophrenia, and some of the symptoms may be related to that. It's also a big proponent of cardiac disease, so we like antioxidants. And in this one, only a group of patients who were on histamine blocking agents, mainly olanzapine and clozapine, lost a little bit weight. This is very well tolerated too, and you can just buy it from the shelves in any pharmacy. I want to talk a little bit about the experience is not that well, and the data is not that that good in the new GLP-1 receptor agonists, and these are like commonly known as their trade names: Ozempic, Mounjaro, Zepbound. There's another name, I think, for the Ozempic, and these medications cause significant weight loss, both in patients with diabetes, without diabetes. These are diabetes medications. They are injectable uh, once a day, once a week, depending on which brand. Um, and two of these medications, the Ozempic and the Mounjaro, are also approved with different names for weight loss. And I mean, the internet and the magazines are full of famous people's experiences, how much weight they lost with these medications. Um, and like, I'm going to show you very quickly the data from the general population. And as you can see, people are losing like, 8%, 10% of their body weight with these medications, regardless of what the medicine is. Some are better than others. The ones who are better have like, double actions. They have actions on other receptors too. Um, but you should remember that all these studies are done where both arms, both the placebo arm and the active medication arm, are receiving intensive lifestyle. So they get the diet advice, they get the exercise advice, they are taught how to change their lives, etc., which in itself very effective, which we're going to talk about. But in general population, 10% weight loss. This is like 10% weight loss to us is like your blood pressure, if you have hypertension, will be normalized. It's very effective, and your life will be longer. In schizophrenia care, I'm happy if I can stop the weight gain, or if I get 5%, I'm really jumping and like high fiving with the patients. Uh, this is the Ozempic. If you stop them, people start gaining weight again. However, they never get back to where they were. But I, as a clinician, think that this is the result of the lifestyle intervention they get, the training they get. Uh, so they're not going back. Some patients are not going back to their habits. So these medications are good when you're taking them. They are not so good when you stop them unless you can continue not eating. The medications are new. We don't know long-term side effects, but one thing we worry a lot is that thyroid cancer, it causes thyroid cancer in animals. It's not clear if it will cause it in humans. We need to see these medications to be used for 10 years or so to figure out that they really would cause thyroid cancer. But at this time, FDA does not let physicians use it in people with family history of thyroid cancer or multiple endocrine neoplasias. This is the Mounjaro, amazing weight loss. On average, people lost 20 kilos, 30 kilos. These are like, 40 pounds, 60 pounds. That's amazing. Uh, these findings are from non-diabetic patients who are in special programs, as I said. However, when you compare it with diabetic patients, the weight loss is less, but still there. And the Mounjaro seems to be a little bit better than Ozempic. But depending on how these patients tolerate these medications can come with quite a bit of side effects when you use them, especially nausea and gastric stomach upset. And this is the reason why most of our patients who are on antipsychotics do stop these medications, although many of them have diabetes and benefit from blood sugar wise from these medications other than the weight loss. The data in serious mental illness, we don't have any data with the new medications, so you're going to depend on my experience using these. but with the older GLP-1 agonists in SMI, which when it's used in weight loss, it's not that impressive. People get metformin weight loss, and metformin is so much better tolerated, so much cheaper. It's like 5 cents, and it doesn't require an injection. Did we use the new GLP-1 agonists like the Mounjaros and the Ozempics on the patients? Yes, we did, but we didn't do in the context of a study. So, but my clinical experience is hit and miss, and the results are not nearly as impressive as they report in the studies in the general population. And about 50% cannot tolerate the medicine. Another 50%, maybe like, 2 out of 5 people, can stop the weight gain and can lose significant amounts of weight, which, is better than the results we have. They may have other neuroprotective effects, which might help in schizophrenia, but this is not well studied. And the reason that I can't study these medications is that they are very expensive. They are extremely expensive, and there is so much demand in the world that the companies do not provide it for free. They are difficult to find. At one point, there was none in the pharmacies, so the compounding pharmacies were making fake ones. Not fake, but not from a factory. So we didn't have the opportunity to study these medications, and with the new federal grants situation, I don't think we'll have the opportunity to study these medications for the next 3 years at least. Uh, Lifestyle interventions. So Dr. Tek, you talk about medications all the time. Lifestyle interventions are great. This is behavioral therapy for obesity. The person who started this thing was a doc called psychiatrist called Stankert. He was a psychologist actually. It's based on CBT, behavior change, cognition change. Uh, Although the obesity therapists don't want to accept it, but if you know CBT, you can do lifestyle interventions fairly easily. It's like small changes. Um, just get rid of one Coke a day is gonna save you 300 calories a day. That will, believe it or not, will cause weight loss. Um, this is the gold standard in obesity treatment, is the behavioral treatment. And um, what we call stimulus reduction, again, a concept from cognitive behavioral therapy or the related therapies. Most therapies have this. Uh, is like, some people eat non-hunger eating, that addresses non-hunger eating. Weight Watchers is a lifestyle program, and it's been tried successfully in schizophrenia population. And they're pretty up to date with their literature, let me tell you. Um, it costs money, but they have free. I think they have subsidized programs for our patients, or they used to. I don't know where they are now. Uh, does that work in our patients? Yes, we did the studies. This is from my colleagues at Johns Hopkins. It works. Uh, Now, you may not think that 6 pounds is much of a weight loss, but remember that these people usually continue to gain weight if you don't do anything. And don't look at the control group in these graphs that I'm going to present, because those control groups are selected. These are people who are motivated to lose weight. I mean, who comes into a weight loss study? People who are motivated to lose weight. So even just being in the study and getting weight regularly limits the future weight gain. It's been shown in general population studies that people who weigh themselves regularly uh, gain less weight, regardless of their starting point is obese, non-obese. And we made it an issue in Connecticut Mental Health Center, put scales in every person's, every physician's room. Unfortunately, after COVID, everything went awry, and but we have established rules that patients do get weight in regular intervals, regardless. And in STEP program, our wonderful clinicians are paying a lot of attention to that issue too, and they have access to scales. Um, we did have a program that we handed people scales, and it's sort of worked very well. It's a very cheap intervention. Just give them a scale. It costs like $10 in Amazon. That's before the tariffs. I don't know how much it will be after the tariffs. And this is another study, and there you go. This is the one we created. It's called Simplified Intervention to Modify Physical Activity, Lifestyle, and Eating. The simple study. I actually did take the intervention protocols in the uh, diabetes prevention trial, and I simplified them to the point that the concepts are not simple, but the words are, and used some cognitive behavioral therapy essentials and created this thing. It is in dire need of updating because the diet concepts, when we did the study, have changed over the years. But it's still a very effective program if you if you want to use it. We have manuals in English and Spanish. It's been translated to a lot of languages, including Icelandic. I'm very proud of that. And the results of this one is in the pilot study, people lost weight in 16 weeks from 225 average to 218. And when we stopped the program, they continued losing weight. In 6 months, they lost on average another 4 pounds. So we did a larger study with 145 patients, and as you can clearly see, the active group lost on average uh, 2.2 kilograms. But remember, I'm happy if they stop gaining weight. So I was thinking like having fake studies, because you see my control group stops gaining weight too. So I was thinking like, maybe just paying people to come to a study will make them lose weight. Uh, I don't know if I have that slide here, but we did that study. We paid people to lose weight, and we paid people to come to our simple groups. This was done with bipolar patients rather than schizophrenia patients, but it was still with antipsychotics. And paying people to lose weight doesn't work. You got to teach people how to lose weight. You got to teach them the cognitive behavioral strategies, how to change their lifestyle. The 6 months later, the intervention group continued to lose weight. The clinic group just stayed the same. So it's extremely effective. Sadly, you cannot build this as group therapy, so we had difficulty actually implementing it around the state for group therapy modality for clinics. This is my presentation, and I will be happy to take questions.